Welcome, everybody. This is Sarah. Welcome you back to another Gravity public call. It may be that we have a shorter meeting, but every time I say that, we actually end up having a longer one, so we shall see. We have our last meeting focusing just on personal health literacy today, and then next time we convene, we'll rope in some of those elements of healthcare access we've been planning for. So we look forward to doing multiple domains at once, as we have in sessions past. Next slide, please. Thanks again for joining. We always mute everyone upon entry. We ask that you remain muted just to avoid background noise. We do record every call, and every recording is available after the meeting on the Gravity Confluence after the meeting. As you should know, or maybe you do not know, we do try to work all comments into the chat. We just ask that individuals have chat comments that are in relation to the topic that we're discussing, so there's no side conversations. Please send chats to everybody. If it's sent directly to me, I have the risk of reading it out loud. But again, we really care about our community collaboration, and the easiest way to ensure things get brought to light is to put a comment in the chat, and then often we even pause the conversation and unmute everybody and just make sure we work through details. There are some very intentional community questions later on in the presentation, so I'm hoping we get to have a public conversation regarding them. Next slide, please. This is our standard antitrust practices slide. Next slide, please. We do invite everybody to officially join the project. Every single one of the links that I will be referencing on the slides, you can already see our amazing team is dropping into the chat. So if you're not a member, we invite you to officially join. Just a comment, usually with WebEx, it takes 2 clicks to get authorization to open the next page. But please do feel free to join the Gravity project. And if you want to make sure whether people from your organization have signed up or you've already signed up, as always, the whole list of members is available on the Confluence as well. And pretty much everything regarding what Gravity does, including both the terminology and technical work stream, is available on the Confluence page. All of our policy initiatives, all of our submissions for terminology, our past presentations, that's all available on the Confluence page as well. There's a host of information there. Next slide, please. This is a list of our project founders, grantors, and in-kind support. We both get lots of direct financial support from individuals, but it's definitely a Many Hands Make Labor Light initiative with many colleagues and friends from different organizations helping. So we're very, very grateful to all of the in-kind support that we get to support our work. Next slide, please. The Gravity Project is currently seeking additional sponsors for our 2022 operations. We do our phased work, right? So we have spring build and fall build. So if you're interested in learning more about sponsoring opportunities, please send an email to gravityproject@emiadvisors.net or visit the Confluence page where there's a specific page regarding sponsorship and how to do so. Next slide, please. This is a very brief agenda, you can see. I wanted to go through announcements with the help of the rest of the team. There are no introductions today. I meant to take that out. There's a project schedule and overview section. We're going to go through personal health literacy and then community homework and next steps. You'll note that there is no formal policy or tech update at this time. Our technical team is working very intently on reconciling comments from the ballot from the SDU too. So that's most of the work, and you'll see how to get engaged in that if you desire by going to the community meetings. Next slide, please. Announcements. Next slide. Mark, I don't know if you're on and want to give an update. There's some things that we've mentioned before on this call, or Evelyn, just to give an update on these.
Sure. Mark is out. He'll be calling in late. So I think most of you are aware, or Mark had shared previously, that he's been working on an RFI response to the RFI released by the White House And so it actually just got extended to, I think, March 3rd. I'm currently reviewing it, but just to let everyone know that it will be published, so all Gravity Committee members can reference what we will be submitting to the White House. Mark's also just starting over on the CMS comments. So this is based on the new proposed rule for the Medicare Advantage program. So he's also working on that. The other announcement, so that's the third bullet. The second one is there's a lot of funding being committed by the federal agencies to ensure, to reduce uninsured rates by CHIP populations, children, and boost Medicaid enrollment. So we wanted to let you all know these are, again, our objective is to incorporate standards at the program and policy level. So we're seeing that. And then last, I think that's it. So the rest, there's other announcements. One announcement I did fail to include here, and I apologize to the community. It's my fault for lateness. We do have a call for pilot participation. So we are starting to stand up, and we will stand up a pilots affinity group. We've been announcing pilots for over a year. So we're in the process of standing that up. So we will, for the next meeting, I'll come in, or Gabby, our pilot lead, will present our approach for convening pilots. So please stay tuned for that. So back to you, Sarah.
Fantastic. And I do want to just mention that the second bullet, the CMS for $9 million to reduce uninsured rate among children, does correlate very nicely to our upcoming healthcare access under insurance domain. So we look forward to trying to integrate some of the priorities from that work into our upcoming domain work that starts at our next meeting. Next slide, please. All right, so this is just what I mentioned before. So at this time, most of the content of the HL7 STOH Fire ID public meetings, which happen on Wednesday from 3 to 4, are discussing and working through the many ballot comments. If you have a desire to attend those meetings, they are open. The ideal is to have the same invested collaborative effort that we have here over at those meetings. So you can view the agenda and past meeting materials at the first link. And then you also can view, you can always access any information regarding the HL7 calendar at the second link. And again, this is kind of the sister of this meeting. It focused specifically on the STOH Fire ID, and we would love to have any people who can attend. Next slide, please.
Laura?
Hi, yes, hello.
Hi. I don't expect a comment on this at this meeting, but I'm wondering for the next meeting if Evelyn and Mark or other appropriate people could comment about TEFCA version 1, which does not include fire, although there is stated to be a fire roadmap. And the actual protocol described in TEFCA version 1 is IHE, which was new to me, although others on this call may know perfectly well what that is. And so I'm wondering how our terminology work relates to how Sequoia and ONC are envisioning the networks that the Cures Act decreed and will now presumably start coming into existence. So that's too big a question to be answered off the cuff right now, but maybe that could be covered in a future meeting. Thank you.
Noted. We will definitely include a response to that in our policy update next time. Ellen, does that sound like a good resolution?
Yes.
Yes, she's yes. All right. Thanks, Ellen. Any other comments here? All right. Next slide, please. All right. Project schedule and overview. Next slide. So this is our roadmap. You can see, as I mentioned, they're actively doing ballot reconciliation on the technical side. We are planning to still cover measures of minority strain, discrimination, and bias likely in the fall. But remember, we have those two approved different sets We have both the community domain sets and the measures of minority strain, discrimination, and bias sets that have been approved for basically, planning and building. It may be because of the planning required with minority discrimination and bias that it gets put to winter 2023, but regardless, those two sets of information are coming after we address personal health literacy, under insurance, and medical cost burden. And again, you can see, as Evelyn mentioned, super excited to start the work of the pilots, and Gabby will come back and talk about that next time. We also have some kind of like grassroots ideas to try to get feedback on some of the terminology elements that we'll be talking about soon. Thanks, Gabby. Just to call out Gabby, so what she put in the chat here was, please submit your pilot interest to gravityproject@emiadvisors.net. And Gabby is amazing and will help connect you to everything you need to know. Thanks, Gabby. All right, any questions on the roadmap here? All right, okay, next slide, please. Any questions about any of the announcements or schedule? All right, next slide. Terminology. Okay, next slide is a terminology meeting today. There's just lots of updates. So next slide. I'm going to pass the mic again to the amazing Linda Hyde. I was jokingly calling this Linda's Corner. I'm going to call this out Linda's Corner now. She's going to give some updates regarding some of our terminology deliverables, and then I'm going to take over one other element next. So Linda, passing the mic to you.
Thank you, Sarah. I just wanted to spend a few minutes telling you about some updates we've made to one of our Confluence pages, the SDOH data elements and status. This is where we post copies of submissions to the different terminologies, as well as providing current information on the domains and activities that have available codes in each of those terminologies. There's the link here that will get to that page for those of you who haven't seen it in a while. One of the changes we made is, since we started putting diagnoses, goals, and intervention codes in Vsac, rather than maintaining code lists in multiple places, we are now on this page pointing you to Vsac so that you can get the latest version of those value sets on, and that will be consistent with what's publicly available for everybody. There's the link to Vsac here. Just a reminder for those of you who haven't or aren't currently using Vsac, to access them, you do need to set up an account. It's a free account, so you just need to provide a username and a login password, and then you can access the publicly available value sets that are in Vsac right now. If you want to focus just on the ones that Gravity is creating for SDOH, then when you go to the search page for value sets, you just need to select the Gravity Project Steward, and all of our value sets that are currently available can be found there, and you can download those. And I believe, as we've discussed in prior meetings, and I believe may have been on the special session that Sarah held where she was describing Vsac, our screeners are not in Vsac right now because there's no current way to tie the screening question and the answer directly in a value set. So right now we are still hosting the screeners with available codes on the Confluence page. There's a link for each domain, and those screening sets have been updated as of January. Our plan is to update both Vsac and those screener lists after each major terminology release. The next scheduled updates will be linked for February. And breaking news, I just saw an email before our meeting that the LOINC February release is now available. So we'll be busy looking at which of our screeners we submitted are now in LOINC and getting those screening links updated, and we'll provide a summary of the changes that are now in LOINC for new screeners at the next Gravity call. And then SNOMED will be available in March. Timing there, I'm not sure if we'll be able to give you a summary of the release from SNOMED at our next March meeting, but certainly by the end of March, we should be able to give you that information. Any questions?
Thank you so much, Linda.
Okay, you're welcome.
The one thing I wanted to mention is that this is where within the terminology division, the information and the final code, the codes are available in our Excel spreadsheets. There is, of course, a correlate to this in a supplemental guide that's available in the tech element in the tech stream. That is not updated at this time, but we will let you know when it's updated because that team is working very diligently on the ballot reconciliation. But just know for right now, the best up-to-date place to go is in the terminology section in this SDOH data elements and status page if you're looking for those line codes. All right. Okay. Next slide, please. Super excited to announce a new kind of task force or work group or subcommittee or whatever we want to call it. Many of you have seen, this is kind of the model that grounds our build. So we publicly identify terms, we review them, identify completeness, we vote on them, the comprehensive sets. Then the terminology team analyzes these comprehensive sets for gaps, and then the terminology team works with terminology organizations to build any critical gaps into code. That's what Linda was just talking about, the end result of that build work. Always on our model, we've had the testing and evaluation element. We make a lot of hypotheses in our work. Some of the work we do, especially in our goal statements, is pretty groundbreaking and very novel. And certainly all of our attempts to create standards regarding interventions is quite novel. And some of our choices we've made regarding the level of specificity with diagnoses is something we've just made choices on. So now we have to test our hypotheses, right? We know that these terms, many of the terms we're talking about, in fact, all of the terms, right, that are on either in Vsac or in the spreadsheets are able to be implemented. So we know individuals are using them in real time. So we're going to be convening a monthly task force of implementers, code users, clinical implementers, whether they're in community settings or clinical settings, to assist with the evaluation of Gravity terminology. So if you're implementing terms, have ideas on function and purpose, we really want you to join us. For those of you who remember our original pilot plan, some of the most ground level piloting as we initially conceived it was really just evaluating the terms themselves, like using them and helping us understand how they're working for you. So as always, the email to send is to gravityproject@emiadvisors.net. And I would just do the subject heading as like terminology task force or clinic, and then we can figure it out how to get you to the right place. Again, if you're using these codes and want to help us with understanding their fitness and their function, please join us in a monthly meeting. We'll get interested parties and then get a doodle poll together and start convening work. Any questions on this slide? Wonderful. I'm so looking forward. As many
Sarah?
Hi, Lucy. Yes.
Sarah, I guess I could ask, once evaluation starts happening, will proposed changes or enhancements or modifications or whatever come back to this group? Or what will you do with the outcome of this evaluation process?
So given that the outcome of that task force won't be, it'll just be a small subset of the broad collective, and given that all of the choices we've made so far have been completely transparent, according to our process, we would analyze themes and suggestions from that task force and then bring them back to the group. Absolutely.
Great, thanks.
Yeah. Thank you so much for asking that. Yeah, we would we would not make significant changes to our process and approach without making sure everyone's aware and on board. All right. Any other questions? Okay. Next slide, please. Terminology identification, and this is, next slide. This is our, it was a tentative, but actually is live now. So here we are and focusing just on personal health literacy. Next meeting, we start addressing the kickoff of medical cost burden and underinsurance. While we address continually personal health literacy going forward, You'll see there's some questions we're coming up with, as we always do, regarding kind of the boundaries of our domains as we go into them. But we look forward and plan on wrapping up the work on these 3 domains by the end of May, and then ensuring that we build and do education dissemination over the summer as we've planned. As you see, the homework is the same across, and you heard me make a very clear plea to this on the previous call. The homework at this stage is always just submitting screening tools, submitting desired, terminology or diagnostic elements, helping us work through necessary interventions, like anything you have that might be relevant. We do ask everyone to do the formal submission process by downloading the spreadsheet from the Confluence, so we can process it. We have a very formal, trackable, transparent process to integrate any changes or updates, but the homework right now across all of these domains is just to get us the things that you're doing so that we can include them in our set and our evaluation. Next slide, please. All right, next slide. This is where we're going to go into personal health literacy and unpack it a little bit more. Again, this is our grounding slide, just making sure that everyone's aware that social determinants of health are not just negative. They offer both protective and risk factors for individuals. And we do look forward, we've talked about, and I think I mentioned this in the last call, having a special session on developing those protective factor terms, because they're very, very critical from a comprehensive assessment and asset space. We know this is the work of social work and care management, it's the work of nursing, it's the work of like accountable communities for health, like identifying both individual and social protective factors is really critical for ensuring the kind of change we desire. So that's going to be in future work as we go forward. Next slide, please.
Sarah, I'm sorry to keep interrupting you, but
No,
if
it's fine.
go back to the previous slide.
Yeah.
On the subject of protective factors, this is also potentially of great interest to foundations and funders who want to enhance protective factors.
Correct.
So I just want to add that. I don't know whether anyone on the call is from that realm, but that's what Prop 10 in California has been funding for 20 years. Thank you.
Thank you so much. Yeah, we're very, very grateful for you calling that out. It definitely is an area that I think we get interested in funding specifically, and just getting all of our both federal and private colleagues to bear. There's, of course, extensive information on protective factors in the literature of agencies of families and community services, because enhancing protective factors is so critical to pediatric well-being. So we look forward to doing that work. At heart, I am a pediatric faculty and family nurse practitioner, so I know that I'm just very, very excited to do it myself. So thank you so much, Lucy. Next slide, please. Okay, Lucy, any other questions, or anybody any other questions? Okay, so now we're going to go a little bit deeper into personal health literacy. It's kind of, if you can imagine, kickoff part 2, which is kind of like unpacking some of the complexity of the elements that we're discovering as we go into the domain. And then there's a little bit of conversation. We might finish early or we might not. We tend to be able to talk about complex things well. So we're going to kick it off now. Next slide, please. This is the slide that Asha presented so elegantly in her presentation last week. We talked about the difference between personal health literacy and organizational health literacy, and that to be clear, the thing that most closely aligns with our previous process, which is measuring it, like the individual's risks and assets. Personal health literacy is the focus of our work right now. But you'll see as we go through in some of our closing questions, this domain in particular is having us ask really clear questions regarding what it means to assess systems, and brainstorming about how to assess systems and intervene on systems in order to address root causes. Because although individuals carry risk, those risks are defined by the communities and the organizations they interact with, And you'll see a lot of that in the themes and the models in health literacy as we go forward. Next slide, please. I wanted to leap off of the World Health, the Healthy People 2030 definitions from the previous slide to talk a little bit about the NLM approach and the World Health Organization approach. So we've talked very in depth regarding digital literacy in our previous domains. We mentioned numeracy in our last presentation. One thing that's very, very clear in the work in health literacy is you can't address health literacy without addressing digital literacy as well. And in fact, there's even a specific subtype of health literacy called digital health literacy. So one of the questions we have to answer in our work is how we build space for the work on digital literacy and digital health literacy, because if our objective is to actually improve outcomes, we really have to make sure that we're including that in our efforts. So we'll be talking about that in a little bit, but I wanted to really unpack the fact that when we're talking about this, we're not just talking about personal health literacy and organizational health literacy. Digital health literacy and numeracy are also very consistent themes in this work and variables in research and outcomes. So digital health literacy, as defined by the World Health Organization, is the ability to seek, find, understand, and appraise health information from electronic sources, and then apply the knowledge gained to addressing or solving a health problem. Examples of digital health literacy include accessing your electronic health record, communicating electronically with your healthcare team, ability to discern reliable online health information, and using health and wellness apps. Numeracy, also known as quantitative literacy, refers to a set of mathematical and advanced problem-solving skills that are necessary to succeed in a society increasingly driven by data, as defined by the National Association of Secondary School Principals. Examples of numeracy include understanding nutrition information, interpreting blood sugar readings, taking correct dosage of medication, example, taking 1 capsule twice a day, or evaluating treatment benefits and risks and understanding insurance cost and coverage. In each of these different topics, I want us to understand how we, in our work in the Gravity Project, when we're talking about domains and subdomains, really try to think about necessary subdomains for intervention, right? So we're thinking very practically, we're thinking about the things that we do to assist the people that we care about, and if there's specific subtypes that are required to identify independently and specifically in order to have specific interventions, we want to make sure that we document those. Examples would be how we broke apart transportation insecurity in our past work, right? Transportation insecurity is really complex, but it's everything from not being able to afford gas, to having a car that doesn't work, to having no available public transportation, to not having a license. So we broke down those subtypes really in order to be able to direct interventions specifically and then track them for outcomes. So Rita's asking, does digital health literacy assume digital access? It does. We have talked about digital inequity in other realms. It's also something we absolutely need to address. Yes, it does. And the rural healthcare provider in me has a specific attention to digital access and digital inequity, given the weight of digital access, especially over the pandemic with telemedicine and teleschool.
Sarah, it's Monique.
Hi, Monique.
Good morning or good afternoon. With respect to numeracy, because with literacy we focus on health literacy and digital health literacy. With numeracy, and insurance is probably health insurance costs, but are we going to, refine numeracy to some subcategory of health-related numeracy, or?
Yeah, so that would be appropriate, right? So, well, again, we will decide that together, right? We identify that numeracy is a critical aspect of health literacy, right? So we could imagine problem with health literacy in numeracy, right? But we also want to make sure that we create terms that are recognizable. You know this. So Monique is one of our amazing in-kind allies and colleagues from the American Medical Association, an expert in SNOMED and very involved in our work with building terms into SNOMED CT. So this is just here to hold space for the fact that's identified as a subdomain. How it gets built out, will be a work in progress. And even if we define, even if we haven't necessarily even defined that we have to build it right now, but these are the terms that we're coming up with as we do our work and our research.
Thank you.
So Mark is saying, we're lifting up the needs to address digital divides in Gravity's letter to the White House on strengthening community health through technology. Thank you, Mark, for your brilliance in this area. And then we have a commenter, there's no dumb questions. Are these definitions for the general public? And yes, they are. So you can see we are evidence-based. So there's hyperlinks at the bottom for sourcing. And then our process is to pull any of these definitions onto our Confluence page for the domain as we work through them. There's complete transparency. So even if you miss a meeting, you can see the terms that we're working through. And then eventually any term that we define that we need to be built also has to have a common definition that grounds the term itself. So these are the working terms of the concepts. Every term itself is also defined, every program type, every domain, and every subdomain. And all of the domains and subdomains, those definitions are available on our on the data sets. So isn't digital health literacy too full? General digital literacy might be high for an individual, but depending on provider insurance and how often it changes, contributes greatly to the ability to find and navigate information. That's an interesting conversation. I'm trying to figure out, I don't know if I quite understand what you mean there. Are you talking about how the instability of systems complicate digital, well, the instability of any system that the individual is interacting with complicates literacy within the system. If that's what you're saying, that's completely on target. And there's a model about that in a slide.
I think just general, looking at the information, you know, the average adult changes jobs 12 times in their lifetime. So
Yeah.
every time you change a job, you're getting a new system, you're getting a new insurance. When
Correct,
you move,
yeah.
you're getting a new provider, and they all have different systems that are branded to sell that particular digital divide. So you're having to relearn a completely new system.
Yes, so that even though I said it incredibly abstract and conceptual, that is
Okay.
exactly what I meant to say, right?
Right.
The instability of systems offers a barrier to literacy regardless of the system and regardless of the type of literacy, right? So it's within stable systems. And if we go on to the next slide, we'll see some models regarding this.
Sarah, don't forget instability of information that I
Correct.
chatted in the chat.
Yeah, absolutely, right? So one of the things, again, you heard me mention this in our kickoff, and I think this is kind of a brewing theme through our work with the Gravity Project, is really trying to build space for what it means to not just think about, not even just think about the individual and communities, but make sure that we're building space for addressing the barriers in part, or the tools imparted by the systems that they're interacting with, right? So the World Health Organization has lots of information regarding this. This is from a presentation on the health literacy toolkit, which is really about how health literacy and the health literacy responsiveness of services interact to create, to enforce, and enhance health literacy. And it talks about the elements of decision making for adults. The reason, again, being that when we think about interventions, and this is, and this kind of goes along with what you were saying, if I'm saying your name correctly, and Lucy, you can talk about these elements of health literacy responsiveness, which also go into those kind of, in the US perspective, those elements of organizational literacy are about availability and accessibility of data, right?
Not to mention cultural competence and language. It's
Oh, yes.
a little surprising to me that that isn't in this otherwise beautiful and thorough diagram. But if it's not in your language, this diagram isn't going to help.
Yeah, so if we go into the next slide, Lucy.
Okay.
I feel like you're the star pupil of the day.
Great minds. Okay.
No. So this is from the National Academy of Medicine report called Health Literacy, a Prescription to End Confusion. And the reason why I highlighted this model is, again, in the Gravity Project, we're always trying to think about not just the problems, but interventions and how we intervene, right? So the NAM report talks very clearly regarding these 3 areas of interventions, and the goal is to improve health outcomes and decrease cost. So one is with culture and society, Lucy, right? 2 is within the health system itself, and then 3 was in the education system. And you can imagine how each of these 3 would play in, and you can imagine how we might need to unpack and continue to unpack what we think about when we say interventions, to ensure that we're not just thinking about interventions for the one, but interventions for the many, right? Because when we think about our interventions, we're usually talking about interventions that I, a clinician, a social worker, a community health worker, are doing for an individual person, right? But this is again from the National Academy of Medicine's report, which is quite lovely, on health literacy, a prescription to end confusion. So when we talk about our interventions and are building out our interventions, we're going to be trying to think of it through this framework. Any questions here? All right, next slide, please. This is, we actually got a really lovely email from our amazing community member, Lolita, asking us to reference the BU Health Literacy Toolshed and their subdomains. We were happy to be able to reply to Lolita that the Boston University Health Literacy Toolshed and its subdomains were already a critical aspect of our kind of environmental scan. As a reminder, the Gravity Project invest very heavily is kind of building off our initial orientation with the compendium of social risk tools that was published with myself and colleagues at UCSF Siren on assessing the lay of the land. So our first data sets are always from our research, from doing environmental scans, from trying to make sure we're folding in the literature and key population health and individual health efforts. So the BU Health Literacy Toolshed is quite extensive. It's a pretty amazing collaboration from friends at BU and then friends at RTI. And then I'm suddenly forgetting the name of the nonprofit that's very involved in that, but they do have these subdomains. Some of these subdomains may be too granular for our work, but they're important to understand, just as some of the measures you'll see coming into our screening tab will reference perhaps one, but not all of these health literacy domains. Lolita, thank you. Lolita is really just a consistently amazing member. She always helps us with submissions, and we're very, very grateful for her help always. Again, this is a use case thing. We're going to try to figure out how many of these are necessary within our work and as subtopics as we go forward. There's kind of a gleaning process we do when we're doing terminology builds. Sometimes it starts very large and we just winnow it to necessity, but there is I don't know if I included the link, but there will be a hyperlink to the BU Health Literacy Toolshed on the Confluence in time. Next slide, please. This is just wanted to reference because what I just said on the previous slides might seem abstract, but there was a really lovely paper that talked about kind of a conceptual schema and the application to the health literacy questionnaire. And I wanted to just go through that. So it talks about there's the schema of health literacy and then how it matches to health literacy questionnaire domains. And these domains correlate to the previous tab on those Boston University health literacy domains, right? So we have basic and functional health literacy, which is sufficient basic skills in reading and writing to be able to function effectively in everyday situations. And the questions within this amazing tool called the Health Literacy Questionnaire are having sufficient information to manage my health, ability to find quality health information, and understanding health information well enough to know what to do. And thank you, Teresa. And then there's the next kind of broad element of the schema is communicative and interactive health literacy. So this is more advanced cognitive and literary skills that together with social skills can be used to actively participate in everyday activities, to extract information. Can I make this a bit bigger? Oh, I'm sorry. I know. I think maybe we can. And what I'll do is I can download the information on this table and put it on the Confluence as well. I'm sorry, Denise. I'm 46. I should know better. So these are together with social skills can be used to actively participate in everyday activities, to extract information and derive meaning from different forms of communication, and to apply new information to changing circumstances. So these go along with feeling understood and supported by healthcare providers, actively managing health, social support for health, ability to actively engage with healthcare providers, navigating the health system, and ability to find good quality health information. In these questions, you can hear some of the themes from the Healthy People 2030 domains that measures that we talked about in the last meeting. And the last one is critical literacy. These are more advanced cognitive skills that, together with social skills, can be applied to critically analyze information and to use this information to exert greater control over life events and situations. This includes actively managing my health, social support for health, and appraisal of health information. I do want to state, as we talk about all the time, and I think I say this on the slide later, all of these social domains and behavioral domains, they all are a Venn diagram of complexity in the person. So you can see very clearly how some of the education themes we have from our less than a high school education domain and some of the programs we have in that realm might benefit this domain. You can also see very clearly how some of the subdomains and elements of our social connection domain would be appropriate here as well. So what we're really developing over time is a library of different, programs and interventions and themes that can be drawn forward to address the specific needs of the person at that time. Sonali's asking, hi Sonali. So Carlos is asking, are there examples of where the health literacy questionnaire is used as part of shared decision-making approaches between, there actually is a lot of literature on that. If you type in health literacy questionnaire and shared decision-making, there, I think there's, in a quick query, I asked myself a very similar question. There's at least like 10 papers that popped up pretty quick for me there, Carlos. And then Sonali's asking, what about the ability to distinguish between information from reliable and versus unreliable sources? So if we look back on the media literacy element, this is actually incredibly relevant when we're thinking about what's going on right now with COVID-19. So there are some questions within our measures that focus on just this.
Sarah?
Hi, yes?
I'm wondering whether there's a time dimension to all of this understanding about literacy. In fact, one can spend a lot of time on the left-hand column, at the left-hand rows here, like hours. On the other hand, there are some things that might be labeled literacy that people need to be helped to understand within a clinic visit, how many pills to take or where to get the pills. So I guess I'm wondering, in the theory that you're covering now about health literacy, whether anybody ever talks about there are priorities here or phases or something where some information needs to be conveyed and understood relatively quickly, whereas understanding your EOB is going to take you hours, and you might actually have to ask for help. So is there a time dimension going on here?
Absolutely there is in practice. There's no question of that. And I think about this again, and I apologize. I always ground my approach to this in my own, hi, I'm a level 3 patient-centered medical home and a team-based model that has measures on health literacy that I have to meet every day, right? So I didn't pull those elements forward, but if you look at the literature on health literacy and team-based care, or there's a lot of conversation regarding priority setting. And Carlos brought to light some of the shared decision-making elements. I think about like the Mayo Clinic's clinical decision-making tools that kind of are merging of health literacy and clinical decision-making, really focusing on that moment, that quick moment in time in the clinic visit. So although we haven't called them to light here, it's very much in the literature, and it's very much the example of this being a team sport, right? So it depends on what kind of literacy you're trying to address and what your team is, but it's very much there, Lucy. You identified something that's 100% acknowledged. Depending on, and we think about this often in like the care planning and discharge planning that we see nursing and social work do all the time. Right, so you identify risks. I was an inpatient nurse for a huge chunk of my life in pediatrics. We identify knowledge areas that are required for health, like post-discharge. we work towards them through the admission and then understanding and demonstrating competency in those as part of discharge planning.
Great, thank you.
All right, any other questions here? Again, this is trying to help some of these abstract concepts become more tangible for all of us as we start to do this work of building language together. Next slide, please. It's already 4:45. I was like, it's going to be a quick one. It might actually, we might not spend too much time. So this is, so one of the things that we are asking ourselves, and Monique is really right to call this to mind, she's a critical element of our team. So we have decisions to make, like, do we include measures like screening tools for all subdomains of health literacy in our screening tool set? Do we address digital health literacy independently and merge it into digital literacy that we've yet to address? Do we craft diagnoses and problem subtypes for each of the subdomains, or just a general problem with health literacy concept? And just FYI, this is problem with health literacy is what we see is proposed in ICD 1011. If we are crafting individual subtypes, what are the use cases for these expanded terms, right? As a young person, I love the Denise. Right, because we really want to make sure that we're creating terms that are kind of a first, critical needs met terms. So if we do create multiple subtypes of health literacy, what would be the use cases for these expanded terms to make sure they're practical? And then in general, and you've heard me talk about this throughout the presentation, we really need to think both now and in the future how we plan well to not just assess communities and community assets, but also assess systems and systems responsiveness, right? So there are a lot of amazing tools to assess systems readiness, systems literacy, systems social justice elements, systems capacity, and how well they respond to meet patient needs. And this is beyond just, HCAHPS, like patient satisfaction surveys. We're really talking about from a social justice, social determinants of health lens. So even though we have community domains on our agenda, our project plan, we really have yet to figure out how we would, or if we should, assess the systems themselves. The reason that I'm holding this to light is because it becomes very, very apparent in the work of health literacy because of organizational health literacy. But as I always state, and I'm stating it again, it's really where the action needs to happen in order to address some of the injustices that we are seeing and the barriers we see. So there's not necessarily a conversation that has to happen here, but just know that these are the things that we're weighing. And if anybody has any particular thoughts on them, we're happy to hear them. Oh, so Denise is asking, where does misinformation fit? So reliable versus reliable sources would kind of cover that, as Sonali was talking about above. But literacy and misinformation are different topics. Assessing the correctness of information is kind of a more classic health literacy concept, whereas unpacking misinformation would be a different topic altogether. Any other questions or thoughts here?
Sarah, I think we all are aware of research that has documented with respect to misinformation, and in particular vaccine hesitancy, that hearing things from people you trust is essential, not to mention what they say and how they say it. So in talking about communities and systems, from my point of view, systems, as someone mentioned about 30 minutes ago, like your health insurer or your employer, are closer to people when they have to make or are presented with health decisions than communities and community assets. At least that's my working assumption here. And so we don't have unlimited resources or time.
Well,
I would think on the other hand, systems and system responsiveness are much more complicated because there's an infinity of systems. So, but I think a decision has to be made one or the other, or explain to me how they relate.
Yeah, so I think I could unpack this a little bit, and I'm sorry if my examples were not clear. So our previous model has been very much within kind of the social determinants of health concentric ring model, where you have the individual person's experiences, which is my experience of food insecurity. And then there's the community experience, which is community food insecurity, food access, right? So we do know, we already plan on addressing food access, neighborhood safety, access to water, right? Digital inequity. These are all things like the individual interacting with a community that that has concerns or barriers, right? But what we haven't talked about is the element that is highlighted by organizational health literacy, which is the business or the hospital or the clinic or the insurer, and or the educational system or the carceral system or whatever system, right? So we talk about the community, but we don't talk about those system level actors. And there's a lot of literature out there on just them. So that's what I'm trying to talk about here in the dichotomy. And it's not really a dichotomy because they're kind of nested, but we already do talk about community and community assets because of our planned work on food insecurity, on food access and neighborhood safety and the like. And there is already literature on systems and systems responsiveness, and it's highlighted in the organizational health literacy because that's an organizational assessment, right? Like how ready, like how responsive is the organization in a health literacy framework, because that's where the interventions would have to go. Is that helpful, Lucy, or did I make it more complicated?
It's another data point. Thank you.
Yes. Hi, Susie. I don't know if I can actually, so can you explain more about the relationship of discerning misinformation and disinformation as part of digital health literacy, especially given the proliferation of mobile digital health tools that make discernment more challenging? Thanks for bringing this up. I don't know if I actually am the best person to explain more about that right now. I'm happy to go back and kind of unpack that in the future, but I definitely identify that it's super critical. I think that probably some elements of that would be, let me just, what I'm going to have to do, because I'm a researcher, is go and look at the literature on the intersection of digital health literacy and tools, right? But I don't want to answer incorrectly and answer that right now. Susie, is that okay? Susie Hall is one of my heroes, by the way. So Art, I'm happy to share the tools on organizational health literacy, even though we're not referencing it right now. And then because they're out there, there are tools for assessment. If we go back here to the organizational health literacy slide, and then I think we're actually probably close to closing. But if we can go back to the beginning and look at the definition. I'm so sorry. This is a way back. One more, I think. Right. So these are assessments of the organization and system themselves are. So it's the degree to which organizations equitably enable individuals to find, understand, and use information and services. So it's both from the perspective, there's tools that are from the person's perspective, right? And we actually see these in some of those questions on the health literacy questionnaire, like some of them are, or how able is my person doing this, but there's also other tools that are specifically regarding assessing the organization themselves. Like in some of the Healthy People 2030 elements have elements of organizational health literacy about like provider meeting needs and meeting them where they are. Was that helpful, Art? Okay. And then Tim saying, great work here as a newbie to the Gravity Project, getting up to speed and enjoy learning about building. Tim, I don't know if I quite understand. So we are the language makers, and then the language makers are, insofar as assessing impacts, we enable the study of them because we have the standard to do so. I think maybe I answered your question. So any other, if we can go back to the end, if there's anybody that has any other questions, please let me know. Other than that, because there is no policy update and there is no tech update, the primary homework, next slide. Oh, sorry, there's one more slide and then I'll close. I apologize, I forgot about this one. So I just wanted to close. Wonderful. So Tim, send an email, that'd be great. You can send it to gravityproject@emiadvisors.net and it will make its way to me and us and the team. So I just wanted to mention, we're again convening a task force and council to assist with discerning necessary interventions. I already have gotten an email from somebody who's on the call today asking to kind of do similar work. So the idea will be to look for community experts in connecting individuals with necessary resources. It's possible, as I mentioned, that many of the programs will be shared with our previous domains, such as education and social connection. I brought that to light already. So please send an email to gravityproject@emiadvisors.net. So if the other one was the Terminology Task Force, this is the Interventions Council. We really appreciate the help and support of our Interventions Council members who helped us with the demographic elements last fall. Really important and critical work. And again, you know, experts in this are the social workers, the community health workers, the navigators, the case managers and care managers, the connectors, right? All the people who really help the nurses who are doing discharge teaching, like any of the people who are actually working with the patient to ensure the needs are addressed. And then next slide. All right, any other questions? Okay, next slide, please. All right, next, as always, the objective is to submit any comments and screening tools and ideas for domains and domain definitions and programs interventions. So please submit those. Here's the link. And then there's also a link for the other domains. Jim's saying, let's make sure we get volunteers for this interventions council that represent the aged. We really want to give a specific shout out to our friend Courtney Baldridge, who was very invested and engaged in this work in the fall. So she was a friend for N4A, and we are very, very grateful for her. And we definitely will make sure that we reference our friends at ACL and the work that they do there. Will the interventions work group insert for the work in the so this specific interventions work group is just focusing on terminology build. So Rita, I do not, maybe so, but I'll need to know the use case for why that would be the case. Any other questions before we close? Again, this was just terminology because we had no policy and tech update, but we did use our whole hour. Thank you, friends. As always, a pleasure. Please send any thoughts or concerns or ideas to the Gravity Project. We're happy to have all of you as part of the Gravity family, and we look forward to meeting you again in 2 weeks when we start addressing the elements of healthcare access under insurance and medical cost burden.
Thank you, Sarah.
Thanks, Sarah.
Thanks, friends.
Take care,
Really
Sarah.
thought-provoking.
Bye.